We'll discuss about the medications. I mean, really in treating the patient, you need to have a really comprehensive management of the patient. It's important to deal with these lifestyle, psychosocial aspects as well. So with regard to the medications, Alon, what are the medications that we currently use for narcolepsy?
Sure. So continuing along the line of a holistic approach to the management of a patient with narcolepsy, the traditional medications for narcolepsy really historically have been the psychostimulants. The psychostimulants have been around for probably the longest period of time. They do work, they work very effectively, but they often have some undesirable side effects, often related to their mechanism of action of being somewhat sympathomimetics.
Yeah. So specifically you're talking about the amphetamine agents and methylphenidate being the main ones, is that right?
Exactly. Now, in the 1990s, we've seen the development of a rather new mechanism or a new medication that uses actually two medications that use two different mechanisms of action. One is a wake-promoting agent. We're specifically talking about modafinil, and later on armodafinil, the isoisomer of modafinil. The wake-promoting agents have in their advantage the ability to be taken once a day without inducing the sympathetic hyperactivity that is often unique to the amphetamine-type medications, the long amphetamine-type salts. Sodium oxybate also came around at the same time. Now, sodium oxybate is very different than the traditional stimulants in that it's not a stimulant and it's not taken during the daytime. We all give it at night. And it works by fundamentally improving nocturnal sleep. And when nocturnal sleep is improved, daytime function improves as well. So it is, in fact, a hypnotic, and it does work in consolidating nocturnal sleep. So those are the four primary treatments up until recent, with newer ones now being available that really make our new mechanisms of action and new opportunities for management.
Now, do the traditional stimulants and the modafinils, do they have any effect on the cataplexy, or are they just for the sleepiness?
So the traditional stimulants do have some effect on cataplexy. The traditional wake-promoting agents do not. So that is one differentiation that I would make, although they're not marketed and they are not prescribed specifically to address cataplexy. But if we had a choice in someone with narcolepsy type 1 versus type 2, someone who had more difficulties with cataplexy, certainly a stimulant may have a better activity. But the one drug that is currently the only one in the United States that actually has an impact on cataplexy is in fact a sodium oxybate.
Yeah, that's the only one that's FDA approved for it. Do you think some of the effect of those stimulants, when they do have a slight effect on cataplexy, do you think it's mainly because they are affecting the alertness and sleepiness, and that therefore there's not that pressure for developing cataplexy, or do you think it's a more specific effect on cataplexy?
I think it's more of the former, in that they do tend to affect alertness and indirectly reduce the propensity for going into REM sleep or inducing a REM intrusion, rather than specifically working on the underlying mechanism of action of cataplexy.
Now, how about in children, Karen? Are these same medications used in children?
Yes, so in children, I think psychostimulants are probably the most commonly used. The only FDA-approved medications, I should just start with, are psychostimulants and sodium oxybate. As of 2 years ago, there was a clinical trial showing efficacy. So that's been added to our regimen.
So the modafinils are not
Well, modafinil is not
for
approved for children under 17 years of age, but certainly is used clinically and has been shown to be fairly safe. The reason it wasn't approved is there were a handful of cases of Stevens-Johnson syndrome in the pediatric, some cases, and so it didn't receive the approval for daytime sleepiness for that. And I think just, patients should know that it can interfere with birth control, and so there's maybe an increased risk of pregnancy if it's taken. So those are some considerations. And then otherwise, in children, we also use SSRI, SNRI medications to treat cataplexy as well.
Mm-hmm. And the sodium oxybate, it was only just recently approved for children, I believe.
Yeah, so it was just recently approved for the treatment of daytime sleepiness and cataplexy for children 7 years and above. And it was shown to be very effective for the treatment of cataplexy and sleepiness in those trials, and side effects ranged from a whole host of minor things, but including nocturnal enuresis, dizziness, feeling unsteady on their feet, and weight loss. And then there were a few cases of more severe side effects that affected mood, the development of central sleep apnea, and there was even a case of suicidality in that cohort.
Mm-hmm. But in general, is it fairly well tolerated in children, would you say? I mean,
Yeah.
People have been concerned about sodium oxybate because it's a derivative of gamma hydroxybutyrate, and there's been a lot of question about using that in adults, and yet now we see this drug is FDA approved for children. So in general, do they tolerate it pretty well?
Yeah, and exactly. So the patients benefit because it treats multiple symptoms of narcolepsy. It treats the daytime sleepiness, it treats the nighttime sleep disruptions, it treats cataplexy. So in many ways, using less medications for the pediatric population is an advantage. And they do tolerate it well. I mean, the dosing is different than the adult population, and oftentimes I'll slow the titration in the pediatric population, and that helps avoid some of these side effects that I talked about. But you do have to counsel them and follow them closely for any concerns of mood issues that may develop along the way.